So, Dr. Ramkrishna, can we uh, start recording?
Yes, sir. I'm sharing the live link, YouTube live link. One
Yeah,
sec.
yeah.
Just 10 seconds, sir. Yes, sir. Live link is on. Recording started. Over to you, sir.
Yeah, welcome Dr. Ashish and Dr. Dharna. They are moderating this session, and Dr. Ashwini is presenting the second piece of this cerebral system. So, Dr. Ashish and Dr. Dharna, you can introduce yourself, followed by Dr. Ashwini. Then we can start. Yeah, Dr. Ashish, are you on there?
Yeah, hello.
Yeah, yes.
Yeah, hello, I'm Dr. Ashish. I'm a consultant neurologist at Bailalamit Hospital in Vadodara, Gujarat, and happy to be here.
Yes, sir has completed movement disorder services from Sri Chitra and Dr. Jarna.
Good evening, everyone. I am Dr. Jarna Bhanushali. I am working at Bombay Hospital. So happy to be here.
Yeah, Dr. Ashwini.
A very good everyone. I'm going to go ahead and start presenting the case if it's okay. I'm Dr.
Yeah,
Ashwini. I'm from Ocular, Mumbai.
yeah, good.
Um, okay. So my patient is a 25-year-old gentleman who's a resident of Mumbai. He works at a stationery store. He's class 10th educated, right-handed, and unmarried. The history was predominantly by the patient. My patient complained of imbalance since 13 years, tremulousness of his hands since the last 13 years, and slurring of speech since the last 11 years. The patient was premorbidly healthy with average scholastic performance and has studied till class 10th. In morning, he manages his own personal grooming hygiene, eats his breakfast, works at the stationery shop where he manages work for 6 hours, and later he watches television and is otherwise a low functioning individual. The patient was born of a non-consanguineous parentage at term without any perinatal issues with normal milestones and is second of two siblings. He was apparently all right till 13 years ago when the patient himself was 12 years of age. He started having imbalance while walking at home. His mother noticed that he would walk like a drunken person with some sway. This was accompanied by difficulty in guiding his foot into the footwear, and he required to hold the footwear against a wall. Even maneuvering his leg into the pants was difficult despite giving adequate visual guidance. However, he was not falling, he was not tripping, he was not crossing his legs while walking. He did not have any difficulty in bending his knee. He did not have any tightness of his legs. There was no buckling, no slippage of chapels. He also did not have any worsening in the dark, no abnormal sensation on his feet, and he never had any dizziness. He started holding onto a wall while walking when there was a large passage. This he told on inquiry, and there was no episodic improvement or worsening. He also developed some tremulousness of his hands, which started 13 years ago. Initially, he noticed it in his right hand. When he was trying to get a glass of water, he would feel some tremulousness. Often, as he would try to drink, the water would start spilling. He would notice that while eating the food also, it would often smudge on his face. Similar kind of tremor he started noticing in his other hand when he would lift heavy objects like a bucket of water for bathing. There was worsening that he noticed in both his hands when he would hold a heavy plate or jug of water. He also noticed that his handwriting has changed. It had become large and dirty, and progressively he was unable to write with precision and started requiring a writer even in school. Despite this, he could hold his pen well, he could button, unbutton, he could make a morsel with his fingers. He did not have any weakness while trying to lift his hand above head to take a shower with a tumbler. And at rest, he had no such tremulousness. He also noticed some slurring of speech while he was, since he required a writer, he would dictate whatever needed to be written during his exams. While talking with the writer, he noticed that progressively his speech was slow. He would have to take some pauses, and the eventually the writer was not able to understand what he was saying, and he had to change his writer on 2 3 occasions. And because of this persistent problem, eventually he quit school. Gradually, it became difficult for even his family members to comprehend exactly what he was saying when he would talk fast. He did not have any change in his tone, in his pitch of voice. There was no tremulousness while speaking or any loud outburst during the speech. He did not have any difficulty in understanding what was spoken to him, reading, or any syntax formation, or he did not have any new word formation. Additionally, on inquiry, he had no forgetfulness of names or events. He had no difficulty in navigating, no difficulty in identifying faces which were familiar, unfamiliar. Even calculations were not very difficult. No mood and behavioral changes were noted by family. There was no blurring of vision, no double vision, drooping of eyelids, no other cranial nerve like deafness, any vertiginous sensation, no facial asymmetry, no dysphagia to solids or liquids was noted. There was no limb weakness, no paresthesia, numbness, no posturing of limb slowness. He had no history of hallucination delusion. He also did not have any history of autonomic symptoms like palpitations, syncopal events, excessive sweating, cold, clammy hand and feet, early satiety, or bloating. No major bowel bladder complaints, no sleep complaints. For etiological history, I also asked if he had any fever, weight loss, reduced appetite, diarrhea, any recurrent pneumonias, malignancies. None of these were there. He did not even have any history of seizures in the past or any history of headaches. However, on asking, he had a very significant family history. He did not recollect history of his grandparents as to the age at which they died. His own father, who he had got to show us, had tremulousness imbalance which started at 30 years of age, and now his father is 45 and is assisted for all activities of daily living. In fact, he came to us in a wheelchair. Also, his paternal aunt also has tremulousness and imbalance. Additionally, his paternal uncle's daughter, first daughter, she also has tremulousness and imbalance, which started at 15 years of age. He did not have any significant past history. He denied any addictions, and he did not have any drugs ongoing when we saw him. Current functional status was that he managed to walk and do his work, but he was unable to speak very fluently. Earlier, he used to do a job which was a little far away, so he could not catch a train to reach to his job. So he would work at a nearby store, and he had to quit his school due to handwriting changes and his speech changes. He was reassigned to manual work at his stationery store instead of talking to the customers. So to summarize, my patient is a 25-year-old gentleman with chronic, slow progressive, possibly autosomal dominant kind of ataxia, which was involving his gait as well as his limbs, with some action tremor possibly, and dysarthria, without any other involvement of cognitive domain, any cranial nerve involvement, any limb weakness, any slowness. There was no spasticity or tightness or rigidity in his limbs. There were no abnormal sensations, no bladder, bowel, sleep, or autonomic dysfunction in the history. I would like to localize this to cerebellum and its connections. And the etiology, I would like to prioritize the hereditary-degenerative, noting how almost his father's generation, 2 individuals were affected, in his own generation, 2 were affected, and seems to be like some anticipation is happening. So I would like to keep dominant ataxias as a first differential, followed by all other hereditary-degenerative ataxias. Another very less common possibility I would want to keep either is a CV junction or a posterior fossa slow growing extraaxial mass kind of thing.
Yeah. First, we will go to symptom analysis.
Yes, sir. Let us go.
Symptom by.
Yes, sir. So the first symptom, sir, was that he was having imbalance while walking at home, and that his mother noticed that he was walking like a drunken person with a sway. Also, it was chronic, very slowly progressive. He's still independent for ADLs. And this seemed to be like an ataxia because maneuvering his foot into the footwear was difficult despite visual guidance.
So here, I think directly appearing like an alcoholic, that should happen relatively late. You should have asked how he was walking initially, how he was playing with his peers or brothers, sisters, and what was his activity, like walking, running, sports activity. That also, if possible, you try to incorporate.
Yes, sir.
Yeah.
Yes,
And
yes, sir.
then,
So actually, we didn't include it because he kept saying everything was normal, and then he just
yeah,
noticed that.
but then you can say that we probed up about his childhood activities,
Mhm.
which included his sports and routine activities, which he is not coming out with any specifications. Because if
Okay,
you
sir.
directly say that person was already drunken and swearing so much, so that is little odd. At least they should have broad-based gait, or something
Mhm.
of that some indication. And then I think you spoke about tremor.
Yes, sir. That was the next symptom. That his hands, he had tremulousness, sir. And
So I
initially, he
think
noticed he was holding a glass of water.
okay. So in ataxia, the tremor type is, we all know, it is an intention tremor.
Intention.
So the
Yes, sir.
history should come that whenever he's approaching the object, when he was approaching the glass, the shakiness had used to increase. The patient may not say, but then we have to tell them that was it happening like this. And because if we directly say spillage was happening, again, it shows the severity or the state of chronicity, right? So
Yes, sir.
that intention component we have to ask. जब आप जा रहे थे glass के पास, as you were approaching the glass or the object, did you find that your tremulousness, shakiness increased or the amplitude increased like that? Hmm?
Yes, sir.
And why did you ask about these heavy objects and all that?
So I wanted to find out if there was some dystonic component to it. So I was just asking about it.
How heavy objects would affect
Or
dystonia?
rather, sir, basically, more, uh, so most
So what
dystonic
happens
for
when
non-posture.
most of the patients, when they use something heavy, like previously, heavy weights were tied like bands to control the tremor. So when we say that he's holding something heavy and his tremor is worsening, that is little odd. I mean, we should have something very solid to comment on that, right?
Yes, sir.
Yeah, yeah. And I think then you talked about writing also.
Yes, sir.
Yeah. So in writing, I mean, anything else would you like to ask or something? Uh, hello.
So that his handwriting remained large and dirty. Progressively, it became so bad that people couldn't read it. And also whether he could maintain his handwriting in one line or not. So
Correct,
usually if
correct.
it is
Yes, yes.
cerebellar, then they will not be able to write in the same line. It goes up and down.
Correct, correct. So as you said that micrography and macrography, small and large, that component we have commented upon. So large handwriting irregular and line cannot be maintained or the font or form cannot be maintained. Yes.
Yes.
And they will not be able to even maintain the paper. So their trajectory will be so bad. That is the component of dyslexia also, that they will not be able to maintain. If it is very severe, not even maintain the hand or the pen on the paper itself.
Hmm.
Yeah. Then next, then you said button and unbutton.
So I was
Uh,
just trying to say
he
that there
could.
is no distal weakness. That's all I was
Uh,
trying to say.
so I mean, see, because of that dysmetria or let's say ataxia, there should be some difficulty. But the holding of the buttons, because you want to focus on the weakness, holding is relatively good. But definitely it will be slow compared to the other people, right?
Yes, sir, agreed. Yes. That was
And then you
definitely.
said that when he's talking fast, these relatives are not able to understand. Something of that sort you commented.
Yes, sir. That was subsequently,
So
sir. I said,
you usually they will not talk fast. That doesn't happen.
uh,
They always have this staccato component, right?
yes,
मुझे प्यास लगी है. So every component they will stress upon. You know what is staccato, no? See, when
yes,
we
sir.
play buttons on the piano, suppose you play individual button, sa, re, ga, ma. So that is called as individual button playing pattern. That is staccato. But if you just play it very fast, like simultaneously, if you roll the buttons from left to right, that is like a legato. So this we should know. So that is a rhythm continuous, that is legato, and what is separate, that is staccato. So that every letter would appear as a separate staccato phenomenon. Okay.
Okay, sir.
Yeah. Yeah. Then you said navigation was not difficult, something like that.
Yes, I was just
So
trying to
navigation, what you meant was, I think, visuospatial.
Yes, yes, sir.
Okay, okay. And why did you
And
ask about mood and behavior?
so, basically, whether there was some psychiatric features additional to this only for that purpose, sir.
How would they like have any significance or relation in this?
So, ataxias with leukodystrophies can have some cognitive features. Then, so that was the only reason why I had asked it.
Okay, and cerebellum itself has got any other
Yes, sir.
effects?
CCS means cerebral cognitive affective syndrome, sir, like the Schwammerman syndrome. So, where
Correct,
they have mood and behavioral changes as well.
correct, correct. Okay, okay. And why this autonomic thing?
So actually, he is 25-year-old. So really, MSA is not a differential. But since
Mhm.
cerebellum was so widely affected, I thought I should not miss out on that.
Okay, and I think everyone must be aware of the GI history, this diarrhea, weight loss. Why headache? Why did you ask for headache?
So headaches again, with mitochondrial disorders, we can have headaches, sir. And other things
Mhm.
such as, although this felt like a very genetic or familial ataxia syndrome,
Okay,
I was
structural
thinking
etiology, you want to see whether there is any tuberal
structural
phenomenon
etiology.
or
Posterior
no.
fossa, CV junctions, they can all have some amount of headaches. So
Okay, okay. Structural etiology is correct, correct. Any other condition can have headache? Any particular condition can have migraine? Any particular disorder? Any
like
episodic
episodic
ataxia?
ataxias overlap, sir, with
Correct,
familial
correct.
CACNA1 gene related mutations. They overlap with episodic
Right, right.
ataxias and migraine.
Episodic ataxias can have almost 30 to 50%
EA2,
of
yes, sir.
patients. I think, yes, yes. Right, right. Again, you should also ask, I mean, if patient is coming out with the history, whether he felt that his eyes are bulging or is there any facial, I mean, vision, of course, you will ask for
So I
cataract and
asked
all that. Any
vision,
facial,
double kind of thing.
yeah, yeah, and facial appearance or bulging eyes, all that we should ask. Yes, yes. Right. If any other comments from other moderators or Shailesh?
And no, sir, I think it's well covered.
Okay, okay. So I think family history, when you told, there was, I mean, everyone can see this family history, which is favoring dominant. So, of course, that I think we'll discuss when there is final details are being discussed. Okay, okay. Shailesh wants to add anything? Is Dr. Shailesh there? I think he might be busy. Okay, then we'll proceed.
Yes. So examination, can I proceed?
I think, yeah, we can proceed. Yes.
Okay. So the patient was conscious, oriented to time, place, person. He was well groomed, averagely built, and well nourished. Uh, Vitals wise, sir, he was afebrile, pulse was 80 beats per minute, respiratory rate was 16, BP was 110/70 in the sitting position. I did not find any postural drop. There was no pallor icterus clubbing lymphadenopathies, no spinobony deformities, no xanthelismas, no skin changes, no skin changes in the form of vitamin deficiency signs like knuckle pigmentation. No mat of TB, no marks, pock marks, no telangiectasia, and I could not appreciate any cave rings. My
What
patient's
are
behavior
the
seemed
markers of TB actually
so
on general examination?
So we can see these non-healing ulcers. Then we may see all the
In
TB
tuberculosis. Okay, I think people would more associate them with vascular etiologies. And this tubercular skin manifestations would
so
be
basically all the
relatively rare.
scrofuloderma, the lupus vulgaris, all that. Although here it's not very significant, but so vasculitic.
Okay, so
Related.
I think autoimmune you can of course add. Why this spine deformity and all that? Where you get
So
spine deformity?
SPG7, although that is in recessive ataxia, sir, basically they may have kyphoscoliosis. Again, Friedreich's ataxia, we can have bony deformities. So scoliosis we can have.
Okay, okay. And you want to say about xanthelisma or xanthomas?
Xanthomas, sir, actually. I think it's a typing.
Okay.
Typing plus xanthomas for CTX.
Correct.
Cerebrotent.
So where all can we see this xanthomas?
So one is this cerebrotendinous xanthomatosis.
Which
Where in the
point?
body? Okay. So we may see the tendo-Achilles. We can see them at the wrists. So basically large tendons, and we may see them.
Okay. Even patellar also we can see.
Okay.
And sometimes it is not visible or obvious enough. Maybe in the MRI that can be found. Okay, na? But xanthoma may not be always present. Again, it is 1/3 to 1/2 of the patient's diameter. Right.
Okay.
And Dr. Ashwini, where could you find telangiectasias? Any particular locations? I mean, you're obviously looking for ataxia telangiectasia. So where particular site that you can find this?
So we would look at the eyes first for the conjunctival telangiectasia, and then subsequently we would look at the upper half of the body on the chest wall and on the back.
Mainly significantly pinna of the ear also.
Okay.
Yeah, go ahead.
Mood and behavior was normal. Higher mental function wise, patient was well groomed. Comprehension was intact. Attention forward digit span was 5. Backward attention digit span was 4. MMSE lost only 1 point on attention. When I did his FAB, he scored 8 of 18. He lost all points in all except prehension. But predominantly, he kept losing points because he was extremely slow while trying to perform go-no-go as well as conflicting instructions. Even with lexical fluency, he took an extremely long time to perform it and was very, very slow with it. For Trail A and Trail B also, he was very slow. He took 2 minutes and 8 minutes. Categorical fluency, he managed but was very slow. He could manage 10 items of 10. Insight was preserved, judgment was preserved. There were no release signs. On examination further, since we discussed in the last class, I did the CCA score. He lost points on all the domains, and he scored only 26 points. He had no parietal signs, no constructional apraxia as such. There was no occipital dysfunction in the form of facial recognition or color recognition issue. I would like, then on examining his speech, I would like to play his audio.
आवाज पण बसता येत नाही, समोरच्याला समजत नाही मी काय बोलतोय ते.
अच्छा. आणि राजन, आता वय किती आहे तुमचं?
25.
ओके. आणि वडिलांचं वय किती आता?
त्यांचं 45 असेल.
अच्छा. आणि त्यांना त्रास कुठल्या वयाला चालू झाला होता?
त्यांना ते ऍक्च्युली मला काय आयडिया नाही त्यांना कधी चालू झाला होता.
So this was his speech, which I felt was mainly scanning. Then language, spontaneous speech was fluent, although he had this syllable by syllable speaking. Then comprehension was normal, naming, repetition, reading and reading aloud was normal. Then cranial nerve examination, fundus was normal. On eye examination, there was in gaze examination, there was up gaze restriction. Although I don't have a video of that, I have the examination of saccades. So along with saccades, we can also know that there is some amount of titubation occurring here.
Titubation.
Right,
The extremely slow saccades.
right, left, right, left, right,
Back for
left,
saccade initiation, he is
right,
having to move his head.
left.
Even his pursuits were slower, although they are not demonstrated in this video, and VOR was normal. Hearing was normal, other cranial nervous stimulation was normal. On motor
So
examination, that
his range of gaze was normal.
so yes, sir. Only up gaze was restricted, sir.
Okay. And so what you should do first, you should see if the patient is how spontaneously doing on your command, and then you hold the head, and then you see, because for that initiation apraxia, the patient will first move the head, then the eyes. So that we have to observe. And second, for slowing, we have to observe how the eyes are moving and up to what end they are moving. Right?
Yes.
So for that, you will have to hold the head. That appearance did not look like titubation per se. I think during that eye examination, maybe he was doing that. So at rest, you should observe if the titubation is there. Should we take the eye examination in detail now? You want to tell everyone how and what all things are to be taken, or at the end of examination you would like to do that?
So now I can say, sir. So we have to the patient to
You
first
go
look
to
at
your eye
all the.
examination part
Yes, sir.
slide.
Yes, sir. So first, we would ask the patient to look in primary gaze and check all the range of motion of his eyes in all the primary gazes. Then after that, sir, we would check if there is, we'll check version. Then I would like to check like conversions if he's able to do or not while placing a hand in front of him. So there is slow versions and fast versions. So I would move hand rapidly in, ask him to fixate his eyes at the wall, and then move my hand fast towards his face for fast version, and slow version I would move it slowly. Then thereafter, sir, I would like to check pursuits. So I would check his horizontal and vertical pursuits where I move my finger extremely slowly, where they say around 4 to 5 degrees per second kind of movement. And I would ask the person to follow my finger or my hand uh, in horizontal and vertical directions to establish if the pursuits are smooth or whether they are broken and whether there are any intrusions. And then thereafter, sir, I would want to look for saccades. So first I would ask them to do memory guided saccades. So I would ask the patient to look to I or verbally guided, where I ask them to look right, left, up and down rapidly. And thereafter, I would give them a visual guidance and then ask them to look. So I would keep pen on one side, I would stand at a foot distance, keep pen on one side and my finger on one side, and ask them to fixate on the pen and finger alternatively for looking at the horizontal saccades and vertical saccades. Then thereafter, sir, I would want to look for this VOR, sir, where I would hold the head of the patient, ask them to look forward first, then move the head downward and upward to look if the eyeball is moving with the head or remains fixated in one place. Um, so then,
So what are the conditions where you have this vertical supranuclear gaze palsy or vertical gaze paresis?
uh, okay, sir. So vertical gaze paresis, sir, we can have one in
I think your
degenerative
patient is
conditions like.
having that, right?
Yes, sir.
Mhm.
In some of the ataxia, spinocerebellar ataxias, we can get it in. We can get it in Niemann-Pick. We can get it in degenerative conditions like PSP, sir. Then we can
PSP, mhm.
not in his
PSP,
age.
do we get cerebellar features?
So there's a variant of PSP called PSP-C where we may get cerebellar features, which is very rare.
Correct. So it is very rare, but yes, we should know that there are subtypes of PSP according to the pathology located. Yes, PSPC is one of them, but it is very, very, very rare. Even the operational definitions also, they're finding it difficult to kind of define it.
It would be nice if you can classify the differentials, like neurodegenerative, structural, then you go acquired, something like that. That will be more structured.
Yes, sure, I can do that once. Just for up gaze, no, sir?
Yes, yes.
So mainly, so if we can classify it like this, we'll say that for hereditary-degenerative, I would like to classify it like this. So hereditary-degenerative would be spinocerebellar ataxias. Then
Storage disorders.
storage disorders, yeah, storage disorders. We could have Niemann-Pick, we can have Gaucher's. Then
DSAC.
Niemann-Pick, then we can even have it with Tangiers at times. Then okay, then other than that, we can have so, and also we can classify it as nuclear and supranuclear. Then other than that, we can have brainstem injuries, which can cause it. Then we can have yeah, mainly this, and then we can have even this in storage disorders. We can have gangliosidosis, which can have it. Then
Artsacs also can cause vertical gaze palsy with cerebellar symptoms. So you would want to, although it is autosomal recessive, your family history is not aligned to that. Yeah. And then structural, where would you like to see in the MRI?
so structural, mainly I would like to see midbrain.
Dorsal midbrain.
Dorsal midbrain, yeah, periaqueductal and dorsal midbrain. So that is where I would want to see. And around the third nucleus also, either dorsal to the third nucleus as well.
Right. We can go.
Yeah. Then, okay. Can I go ahead with the motor examination?
Sorry, Ashwini, in primary gaze, we would also want to look at the spontaneous movement, whether there are square wave jerks, macro square wave jerks.
Intrusions, yes, intrusions, macro
Yeah.
square wave, micro square wave, yes.
Any oscillations or flutter, all these things would be seen in the primary gaze. So you didn't comment on that. So always mention that also in primary gaze before checking the range of motions.
Yes, the intrusions also, yes.
So your patient didn't have it. He has a slow
No.
saccade, so he won't have it.
Yes, yes.
Sorry, I missed. Was there any comment on nystagmus?
Yeah, you did comment on this. Yeah.
Okay, it was covered. Okay.
No, so I didn't cover it actually. He didn't have nystagmus.
Okay, okay. So anything in brief you would like to tell about nystagmus? What types and typically where would you localize something like that?
Yes, sir. Yes, sir. Yes, sir. So, sir, we would have this. So with cerebellum, we can have different types of nystagmus, sir. So, we can have this gaze evoke nystagmus or rebound nystagmus, which can be localized to the flocculus, sir. And otherwise, we can have this periodic alternating nystagmus, which can be localized to the nodulus. And then we can have this Bruns nystagmus, which again is a CP angle. Hello, was I audible?
Yeah, go ahead.
So shall I localize other nystagmus?
Yes, if you have anything to comment, please tell us. You should also tell about upbeat and downbeat nystagmus
Upbeat
also.
and downbeat, yes, sir. If
Yes,
we are
yes.
thinking of,
Because that is relatively more common.
yes, sir. So if you're thinking of this pontomedullary junction, then we can think about this upbeat nystagmus, sir.
Yes. So midline vermian lesion also, brainstem also, that can be seen. I mean, upbeat can be seen in that. And downbeat, I think you mentioned, that is flocculus. Okay. Yeah. Go ahead.
So motor examination
Anything
wise?
you did,
Yes, sir.
cataracts, have you mentioned? In what all conditions would you get to see?
I haven't mentioned that, sir. Some usually cataracts are seen with this mucopolysaccharidosis and with storage disorders, early cataracts.
Mm-hmm.
And CTX also.
CTX also, yes.
And so can you describe few conditions like eye involvement and ataxia? It can be anything. It can be retinal. It can be cataract.
Okay. So as we said, as we said here, CTX with cataracts we can associate. Again, we can have sunflower cataract with this thing, and KF rings with Wilson's disease. Then we can have with SCA, basically we can have with SCA 7, we can have macular degeneration. Then and eye signs, if we go to say then ataxia with oculomotor apraxia, we have oculomotor apraxias.
Okay.
Then mitochondrial disorders, we can have retinitis pigmentosa. And refsums, we can again have fundus changes. Then tangiers, we can have tangiers, with Niemann-Pick, we can have cherry red spot. Niemann-Pick, we can have cherry red spot, even with sialodosis.
Right. Okay. Yeah. So we can go on.
Then on motor examination, attitude of the patient was normal, tone was normal, power was intact in all limbs, in all range of motion. Dependent reflexes were 2+ in bicep tricep supinator. We got a pendular knee jerk. His ankle reflex was absent. Superficial reflex, well, plantars were bilaterally flexors. While examining his coordination, he had tremor at end of action.
दूसरा था
You can appreciate him. Then he
So
had some
here, when you're examining, so you ask patient to keep elbow little up at the level of shoulder.
yes.
Okay. So try to keep it almost at the shoulder level, because then proximal oscillations will be more visible, right? And you
Yes.
also ask them to do first slowly, and then you ask them to do relatively faster, right?
Yes.
Yeah. So coordination, I mean, I don't know, tremor, when you are saying, then that should come as a part of involuntary movement only, right? And when you say coordination, you should say that whether there is any dysmetria or not. That you have to say,
Okay.
right?
For
And
this,
tremor also you have to specify that it was, hello? So it
hello,
was
yes.
yes, so it was a kinetic tremor. There was a increment in the amplitude or worsening of the tremor at the end when the patient was reaching the target, like finger or back to his nose.
Yes.
So you may not have written, but verbally when you present, you can say that. You re-emphasize that point.
Yes.
Yeah.
Yes. And so there was no bradykinesia. And on his gait examination, while standing from sitting, his gait he managed it normally. Initiation was also normal. His stance also appeared to be normal here. His arm swing was okay. His step height and length was normal. Here he had no turning difficulty, and his cadence was also normal. On sensory examination, pain, fine touch, and joint position sense was intact. Vibration was impaired up
So
unto
your
his.
gait is coming before sense. I mean, gait came before all this.
So in one of the earlier classes, we were told that to complete gait with motor examination. So at our institute, we don't follow this. We usually finish tone, power, dependent reflexes, superficial reflexes, and involuntary movements at once. Then we usually do sensory examination, vibrations, basically sensory examination, cerebellar, and gait at last.
Okay, I think if I remember correctly, in the Dijon, there is a protocol how you proceed with the examination. Try to follow that. Of course, every examiner or every institute would have their preferences, but you can always say that we are following the standard textbook recommended by our teachers or something like that. But anyways, we'll just proceed.
So on sensory examination, pain fine touch joint position sense was intact. And so on examining his vibrations, it was impaired up unto his ankles bilaterally. And later, when we tried to do his Romberg, he couldn't do it because on standing with his legs closed itself, he would fall. Cortical sensations were normal.
So here, what you should do, so whatever minimum distance patient is able to keep for the steady stance, you should do that. Here we are not really worrying about the distance between his feet. The idea is on closure of the eyes, there is worsening or not, or loss of balance or not, right?
Yes, sir.
So you ask patient, whichever patients are regular, whatever minimum distance you can keep your feet close, you keep like that. And of course, you as an examiner should stay nearby and ask patient to close the eyes. If there is worsening, you say the Romberg is positive,
Okay, sir.
right? So just because patient is not keeping feet closed, we should not comment like
Okay, sir.
yes.
So then on cerebellar examination, sir, he had the scanning speech, he had titubation. He had slow saccades. Incoordination was there in his upper and lower limbs. There was dysmetria as well as dyssynergia while doing his finger nose finger test. And there was incoordination even in the knee heel shin test. His rebound phenomena was negative, which means it was abnormal. There was dysdiadochokinesis with both hands, and he was unable to tandem walk.
So what is this rebound phenomenon was negative? I mean, how do you check that?
So the Holmes rebound phenomena, sir. So, sir, basically when we ask the patient to flex his arm towards his face while giving resistance,
Flex the elbow.
flex the elbow towards his face while giving resistance. And as we remove the resistance, the patient's arm, because of the hypotonia, tends to, and because of the incoordination between agonist and antagonist, tends to go more towards his own face. While doing this, we also have to make sure with the other hand that we are protecting the patient's face.
Okay.
So this is
So there are two things. There is something called as impaired check phenomenon.
Yes, sir.
So whenever the patient is putting force, and suppose you remove the hand, ideally it should stop at a certain safety level and should not hit the patient's face. Normally, we all would have that safety component. That is called as a check phenomenon. When that is impaired, that is called as impaired check. There is other way of doing this is you ask patient to outstretch the forearms with palms facing downwards and you suddenly tap. You suddenly tap one of the hands and you see how they are oscillating. A normal person would immediately bring back to his original position. But a person with cerebellar disease will not have that check phenomenon and the arm will or the hand will oscillate. So that is called as impaired check phenomenon. And what happens when the check phenomenon is not good? Ideally, it should rebound on the normal position, but instead of that, it will oscillate more or the oscillation will be of large amplitude. That is called as excessive rebound. Right? We should have a rebound, but with a safety check. But because it is not happening, there is something called as excessive rebound. So you should check impaired check and you should say a Stewart Holmes maneuver for this excessive rebound.
Yes.
Dysdiadochokinesis. Okay.
And he was unable to tandem, sir.
Tandem. How do you check tandem walk?
So initially, first we ask the patient to walk without keeping legs in front of other, like a normal walk. Once the patient is able to do that, in the second round, we ask the patient to place the heel of his foot against the toes of his other foot, back to back, and walk in a straight, as if they're walking in a straight line.
Yeah. So how many steps we ideally should ask patient to?
I'm not aware of how many steps.
If I do only 5 steps as a patient in front of you and if I'm doing well, would you call it an appropriate test or adequate test or a normal test? So ideally they should do at least 10 steps. And if they're missing 2, like out of 10, दो भी अगर abnormal है, तो we call it as abnormal test. Right? But your patient, I think with normal gait also, he was having very bad gait or he was severely affected. I'm sure tandem he could not have done. What is dysrhythmokinesis?
Dysrhythmokinesis, no, sir, I'm not aware of this.
Okay, so if every movement has got some rhythm, especially walking and all. So if you hear the foot tap, it will not be rhythmic. That is one way of checking it. Second, if you ask patient to tap his own finger or tap on the table, we expect a certain rhythm to be present in tapping, like ticking of a clock. But they will not have that rhythm. So that is called as dysrhythmokinesis. What else would you check in cerebellar examination?
So then gait ataxia also is a part of the cerebellar examinations.
So is it coming next in the next slide?
So no, actually I had this one.
Okay. Right. So there is one more term, I don't know if that is asked in exam or not. That is called as isometric ataxia. Means when you are doing an isometric movement, that will be ataxic or it will not be in a good, I would say, rate and rhythm. So for that example, we have to hold the patient's, the patient will hold examiner's finger laterally with like a pinching movement like with the thumb and the index finger, and we expect a certain amount of force. But what will happen when he's holding that force will keep varying. Like if I have to give an example in real life, suppose I am lifting a bunch of papers in my pinch, let's say 3 papers or 4 papers. So I will have to exert a certain amount of force, right? But if I have to hold, let's say 100 pages or something like that, a bigger bunch, then that pinch will have a bigger strength and bigger force. So to maintain that strength, that they cannot do. So that is called as isometric ataxia. Means iso METR then ataxia. It is spelled something like that.
Okay.
Okay, just for I think it may not be asked in exam, but we should know if they ask what are the components of examination. If it could be a credit question. Okay, next.
So then gait, he was standing from sitting was normal, initiation was normal, his stance appeared to be normal, arm swing was normal, step height length was okay, turning was not
So
difficult.
okay, before that, when somebody is sitting, you should also see if there is a sitting ataxia or not.
Okay.
If patient is having very bad ataxia, very severe chronic ataxia, in the sitting position also they will sway. Something called as which you mentioned titubation. Titubation means not just head and neck; it can be trunk or
Yes,
entire body
sir.
also,
Yes, sir.
right? And
Yes.
he's not needing anybody's support to stand.
Hmm.
Okay, fine. So
So he's
always
not
comment
needing
like
support.
that, sitting. Yeah, no problem.
So while sitting, sir, he did not have any ataxia. While walking also in this passage, he managed, sir. But when we made him walk on a larger passage outside, he was holding onto a wall because he was fearful that he'll fall.
Okay.
Unfortunately, we don't have his video. His father, although had
Oh.
accompanied him and had truncal ataxia. I'll just see if I have a video. I'll share it on the group.
No problem.
So then other systemic examination was normal, sir. There was no organomegaly, no abnormal heart sounds. And
Why this
respiratory.
other system examination is important?
So for basically organomegaly, for all the storage disorders, even in Niemann-Pick, we may have organomegaly. Then so for heart sounds, because Friedreich's ataxia and all can have some systolic murmurs. So mainly for that reason.
And what is with the RS?
So respiratory systems, again, that we check, so because recurrent pneumonias with ataxia telangiectasia, so from that perspective.
And skeletal deformities can sometimes cause restrictive airway disease. You can say
Yes.
that.
Restrictive airway disease, yes.
Good point. So very good, valid point.
So, sir, shall I go ahead with summarizing?
Yeah, Dr. Jharna, is it okay? Can she proceed?
Yes, sir.
Yeah. Please go ahead.
So the patient is a 25-year-old with chronic slow progressive autosomal dominant ataxia with tremor with some cerebellar dysarthria with slow saccades and errors on the CCS score, impaired vibration in both his lower limbs without any other cognitive domain, any visual complaints, weakness, slowness, spasticity, rigidity, abnormal appendicular sensations, bladder, bowel, sleep or autonomic dysfunction. With this seems like a autosomal dominant ataxia, which is predominantly cerebellar in nature. So I would want to localize this to cerebellum and its connection, and to the spinocerebellar tract. And then so because of the vibration sense being affected. And etiology wise, I would want to discuss more of the hereditary-degenerative, mainly the autosomal dominant ataxias. More common ones are 2 and 3. So those first. Less likely mitochondrial, because the inheritance pattern felt more autosomal dominant. And then I would want to keep less likely as other autosomal recessive ataxias or even DRPLA because cognition, other domains are not affected.
I think you forgot to write about reflexes.
So I have covered it, sir. Motor examinations, sir, reflexes.
No, in the summary.
Okay, sir, yes. Impaired,
I
yes,
think
sir.
ankle
And
work.
it was impaired, pendular knee jerks were
Huh.
there, yes.
That you should highlight. And tone
Why is
also
it
because
important, Dr. Ashwini? The ankle reflex and the sensory examination.
Yes. So basically, pendular knee jerk is because there is hypotonia with cerebellar disorders, which causes pendular knee jerks, and ankle being absent again with respect to neuropathy can be possible. Although here we are just seeing that there's impaired vibration sense.
So, what is the spectrum of ataxia with neuropathy? Can you name some causes?
Yes. So spinocerebellar ataxia 1, 2, 3 all can have ataxia with neuropathy. Then we can have
No, most
ataxia.
common first. Most common ataxia is Friedreich's. Yeah.
Friedreich's,
I think
yes.
you could
Friedreich's.
say that. Yeah.
Friedreich's ataxia.
Go ahead.
Then with ataxia with oculomotor apraxia and autosomal recessive also we have peripheral neuropathy. Then it's been reported rarely with RSACs also that we can have this thing neuropathy. Then with CTX we have neuropathy. So mainly these, and with ataxia
Vitamin E
telangiectasia also
deficiency.
vitamin, yes, B12 deficiency also we can have, with E also we can have. Then
Tangiers is also neuropathy. Repsim is also has neuropathy.
yes.
Yeah. Or beta lipoproteinemia.
Yes.
Yeah. And there is a
even mitochondrial NARP and everything can also have
Golgi. Yeah.
Golgi, NARP, all this can have.
And also there's a
as a cause for myeloneuropathy, we should remember, as
yes.
B12 you are telling.
Yes. And also there's a spectrum.
Jarna madam, your voice was not audible. Dr. Jarna.
Yeah. So, yeah, is it audible now, sir?
Yeah, we missed your last comments. Could you please?
Yeah. So spinocerebellar ataxia with neuropathy. There is a spectrum called as SCAN1, SCAN2. So there are specific genes for that. You can just review that. They are very rare, but we should keep that in mind.
Yes.
Yeah.
Sorry, ma'am, I think you're not audible.
Dr. Jarna. I think madam's connection could be weak. Okay. Fine. So just because you're discussing cerebellar, other sensory ataxias or neuropathies or neuronopathies, would you like to comment, which madam was also discussing?
So like scan 1 and 2, like those kind with cerebellar components, or like
Genetic are there, but other also.
yes, sir. So nodopathies, paranodopathies can also have basically sensory deficits with tremors.
Mhm.
Then so the hereditary neuropathies also can be there where they can have sensory attacks. Then the neuronopathies wise, then immune mediated like Sjogren's and everything can cause ataxia.
Correct, correct. So with prior history of dry eyes and dry mouth and all that.
And then
And
drug can be
yes,
drug.
drugs we should know. Correct, correct. Right, right.
Then, hmm. Then so
Yes.
even things
So what
like
are the Huh.
so even things like carbon monoxide and all, which are less common, but they can cause both sensory as well as cerebral attacks.
Of course, I think when you are ending the case, I think you will discuss how to approach acute or subacute or chronic. Our case is definitely with clear-cut family history and chronicity. We are more or less narrowing down to our diagnosis. But as an approach, you should always. I'm sure you will be discussing that, right?
Yes, sir. So
Okay,
so
okay.
I'll be
So
verbally
proceed.
so this is the end of the case, sir. For this patient, since he was socioeconomically challenged, we did not have his imaging. However, his father had his imaging where there was cerebellar
So this
atrophy
is the
and
last slide of your case.
yes, sir, yes, sir.
Acha, okay, okay.
And so we had genetic testing for his father and his paternal aunt, both of which had spinocerebellar ataxia 2 on it, sir.
Okay, okay. So, what are the features SC2 I think you could bring in this case?
Yes, sir. So cerebral ataxia with with pyramidal or extrapyramidal features, and they can have neuropathy. And for eye, they have this typical oil in bath kind of very slow saccades.
What is it called as oil in bath?
Bathtub, oil in bathtub kind of.
Okay. So, any reference for this?
So I'll just share it.
Okay, okay. So this SCA2, we all should know that our very own Indian doctor, Dr. Noshir Wadia, yes,
Yes, sir.
somebody has commented. Noshir
Hmm.
Wadia from JJ Hospital, Mumbai, and along with that, his colleague. So it is called as Wadia Swami syndrome. So they first described it, I think, in 70s, right?
Yes, sir.
So people were also referring that as Wadia Swami syndrome. So we should know that SCA2 because there is an Indian reference, our
Yes,
own
sir.
neurologist reference, right? And
Yes.
one more thing is, and other SCAs, if you have to just pinpoint SC associated with, let's say, visual issues, SC
Hmm.
associated with movement disorders, SC associated with neuropathy, something like that, would you like
Yes,
to
sir.
tell the
Yes,
audience?
sure, sir. Yes, sir.
Like
So,
ataxia with chorea, something like
yes.
that.
Yes, sir. So, sir, basically for SCA 1, 2, 3, we have cerebella with pyramidal, extrapyramidal. 2 and 3 have eye signs. 2 and 3 are most common. SCA 5, 6 is pure
Which is the
cerebellum.
most common SCA?
So, 3 is worldwide. Machado Joseph is commonest worldwide, sir.
Yes, yes. And now I think SCA12 is, people are sometimes saying
Yes,
that
sir.
SCA12,
Agarwal
the
is
Agarwal
common in
community, I think
community.
it is kind of becoming common. And
Yes, sir.
SCA12, I think we discussed last time, sometimes initially it will just come as tremor, action tremor. The
Yes, sir.
cerebellar features may not come. So that is a closed DD of essential tremor. I think
Yes,
Dr.
sir.
Jarna is back. We can ask her to give her comments.
Yeah, so involuntary movements with ataxia, did we cover acanthocytosis?
No, we didn't cover yet. We were just about to discuss that. So we first discussed SCA 1, 2, 3. Then I was at
Yeah,
SCA 5 and 6 saying that those are pure cerebella, 5 being Lincoln's ataxia. Then,
right.
yeah, then we had this SCA 10 where we have epilepsy associated. Then SCA 17, which has this HD-like phenomena, where we can have chorea also.
Yeah. Some examiners might ask the genes, so just review that. It's all given in the textbook, so no point in discussing here. But some may require genetic information.
Okay.
So
So
just know
Yeah,
most,
I think common ones we should know.
common ones.
Like,
Yeah.
yeah, I think 1, 2, 3, 6, 12 is commonly done by medgenome. Other, I'm not sure. And as an SCA panel.
Panel.
And
Yes.
yes. Yes.
So, and those are
Then
trying CTG
then
repeat.
DRPLA is also one of the autosomal dominant ones.
Yes, and it's a again, it's a trinucleotide repeat again.
Yes, yes. But then it'll have all kind of cognitive
Seizures.
and
Yes,
seizures.
seizures if it's a
Multiple
younger.
movement disorders, seizures.
Yes. Okay. And then
Yes,
involuntary movements and ataxia.
So just ataxia and involuntary movements, we can have all HD lookalikes. So SCAR 17 is one of them, like you mentioned earlier. And we can have chorea acanthocytosis also, where we have involuntary movements with ataxia. Then
Some types of NBIA.
yeah, pecan can have ataxia, but it's predominantly like chorea is dominant.
Yeah.
Then
Okay.
other like HDL2, 3 also can have ataxia, chorea, but again they have
yeah,
more.
even Ataxia telangiectasia derpla you have mentioned, SCA 1 to 17 you have mentioned. So they
Yeah.
are common, yes. And even the tremor we should know. All these FX tasks they like to ask.
Yeah. So adult onset,
FX,
late.
TS. And clinical, I mean, their MRI pictures and all they like to ask. SCA, you should know some of the important signs. I think this some crab sign or something is in SCA 48 or something. I'm not able to recall well, but you should read about it. Some specific signs. Some have short stature, some have myoclonus, some have tongue fasciculations or atrophy. So one or two, some key features you should know that SCA so and so will have this. I think some ataxias, I think Holmes ataxia, if I'm not wrong, is also having hypogonadism or fertility issues. So that also we should ask in the history.
Right.
Yeah. And again, cognitive also, I think Madam told just now, no? That also we should know ataxia with cognitive issues.
Yes. There'll be a different spectrum, and mostly all those will be in first
I like
decade.
Krabbe kind of and first decade disorders also.
Yes.
And
And
storage
any
disorders.
particular drugs would you like to comment upon? Because
Yeah.
So
drugs was one of the. Hello.
sorry, sir, I couldn't hear your whole question.
Mm, drugs and ataxia.
Yes, sir.
Could you
So
please? Yeah.
anti-seizure drugs such as phenytoin, carbamazepine, these can cause ataxia and mainly ataxia. Then other than that, sir, we can have deficiency of that we can't include here.
Anti-cancer drugs.
Cancer drugs, yeah, many of them can cause sensory ataxia also, sir. So then some metronidazole can cause affection of the cerebellum,
Yes.
so that can cause cerebellar ataxias. Then
Correct. One thing I just want to highlight: sometimes phenytoin can give some nystagmoid jerks or also still nystagmoid jerks. That doesn't mean the patient is having ataxia, right? Even at therapeutic level, they may have that. Right. Yes, somebody has mentioned 5-fluorouracil,
Cytarabine,
cytarabine, yes,
cytarabine.
cytosine, cytarabine. Correct. Definitely, alcohol we all should know.
Alcohol, yes.
Alcohol, there is acute as well as chronic, both we should know. Alcohol and neurology, as it is a big question. We all should know. In alcohol, what is the typical titubation they have?
So I'm not aware.
So there is a mnemonic A for A. Alcohol causes anterior lobe involvement, and again it causes A, that is anteroposterior sway. So you should remember A. Alcohol, anterior lobe, anteroposterior sway.
Okay, sir.
And as opposed to vestibulocerebellum, the sway can be in any direction.
Any
Or if it
direction.
is ipsilateral vestibular affection, the
Towards
patient
the
will feel pushed towards that side. Correct.
that side.
Yes.
Any toxins you want to enumerate? I know it's not relevant to this case.
Yeah, but yes, mercury,
Just to
thallium,
finish.
solvents, and carbon monoxide. Basically,
Yes,
heavy
yes.
metals act there, then toluene, then other solvents can do it.
Right, right. And even all these endocrine conditions, low thyroid, low PTH also we have to, as a reversible causes, we have to
Yes, sir.
enumerate that. Right,
Yes,
right.
yes.
Any particular update about this Friedreich's ataxia? Any drug has come up? Do you have any idea?
Yes, sir. Uh, so I'm not able to recollect the name actually.
It is some
But
Oma Veloxone or something like that. That everyone should, yeah. Oma Veloxone or something. Yeah, somebody's mentioned. So just have a look because for treatable things we have to know. This Miglustat is used in which condition?
Miglustat
Just I'm
is
remembering that.
so Niemann-Pick they are using it for storage disorders
Correct,
basically.
correct. Right, right.
Mm.
Okay, okay. Right. So yes,
Do you want to mention some treatable ataxias? Just
yeah.
name them,
Yes.
and maybe if you can name the treatment with that.
Yes, definitely. So mainly one is vitamin associated ataxias like thiamine, B12, E related ataxias. These are all treatable ataxias. Then episodic ataxias also we can treat, sir, with acetazolamide. And then if it is some toxin related, withdrawing the toxin itself can help. Storage disorders, we can give miglustat for NPC. Then for Friedreich's ataxia, we have this omavaloxolone. So predominantly these, and if it's paraneoplastic ataxias, then we treat them with immunosuppressants. Or if we have
Infectious
pancerebral
causes, infectious, yeah.
infectious cause,
Para-infectious, autoimmune.
Infectious, post-infectious
yes.
autoimmune, yes.
So those
So
we can
common
treat.
infections causing ataxia.
So usually cerebellitis they cause. So varicella zoster is commonly associated with it. So
Right. Common is varicella, yes, especially in the children.
yes,
And
sir.
then others are even sometimes measles
HSV
also
also
can
means
cause,
a measles.
Epstein-Barr can cause. Yes.
Yes, sir.
Somebody's mentioned CGD also. Yes, yes.
CJD, yes, sir. And then
Correct.
Epstein-Barr enterovirus, well, that can also cause.
Yes. And syphilis we all should remember.
Sorry, sir.
Syphilis also we have to keep in mind.
Syphilis, yes, sir. Syphilis, tuberculosis, sir, and even NCC if they have
Yes,
tuberculosis.
correct. If they have structural integrity in cerebellum. Yeah.
Structural lesion related. And then, sir, another thing, demyelination we didn't cover, sir. So progressive MS can also have cerebellar affection. So there we can treat with immunosuppressants and disease
Correct.
modifying.
Even PML also.
EML also, yes.
PML also, yes. Okay.
I think Dr. Charna ma'am was trying to say something.
Yeah. So we can again reclassify as acute, subacute, chronic, or by etiological basis like infiltrative, infectious, so that you won't forget while naming these things.
Yes.
Yeah.
And
Okay,
then
I think
vascular, I think we missed vascular also. So vascular, suppose if it's vasculitis, then treatment with immunosuppressants. And if it is acute stroke related, in case
Yes,
of
acute, whether it is trauma or stroke, that we are definitely considering. Tumors also, we are
tumors
considering
also.
that, yes. Toxin, I think, arsenic, benzene also has been
Yes, and
discussed.
lithium also, I think I missed. And
Yes, correct. So as madam was saying, acute, subacute, chronic, we have to know whether it is focal symptoms or global symptoms, generalized symptoms that we have to know. And age of onset versus hereditary versus non-hereditary, that we have to classify. Right. So I think all this ataxia with movement disorders, cognitive, all this list we all should know. Specific MRI markers we all should know. And yeah, I think that should be fine. Somebody has mentioned Hashimoto's. Yes, Hashimoto's
Yes,
also
what is reversible
we
cause,
have to
endocrine.
update. Yes, yes, steroid responsive. Yes, yes.
Steroid responsive.
Yeah. Okay, I think anything else?
And so
Dr.
gluten
Jarna,
associated.
Shailesh? Yes, gluten celiac, that is.
Correctable, as you were mentioning. So.
Correct, correct. That way even Lyme and malaria also has, because if they cause cerebral involvement, they will have.
Yes.
Yes. Okay. Dr. Jarna, anything further?
I think we have covered it, sir. Anyone else want to add anything? Then we can discuss that.
Yeah, anybody have any question they can ask? Parkinsonism with ataxia.
So all these SCA2, SCA3, they can have this Parkinsonism. By the way, SCA3 sometimes can have levodopa responsiveness also. That is also an interesting phenomenon. We should know that. So SCA1, 2, 3, 17, we should remember. And MSA, we should remember. MSA. Yeah. Even FX stars, we have to remember.
Yes.
MFS is cellular. What about Bickerstaff?
Bickerstaff, I'm not sure whether it causes ataxia per se.
So that Miller-Fisher
We will have
with
to review.
is why I think they are trying to say, but ataxia and Miller-Fisher is not due to cerebellum, but is due to the posterior columns.
Yes, that is afferent ataxia, correct. Okay, one more thing. This Friedrichs, you should know that late onset Friedrichs ataxia, somebody has commented about Friedrichs. Late onset Friedrichs.
LOFA, yes, sir.
Then Friedrichs with
Very late
retained
onset and late onset.
reflexes. Yeah. And retained reflexes also. They have this component. Okay, okay. Okay, I think ultimately everything cannot be covered in short lecture. It was a good discussion.
So if there are no further questions, we can conclude this session. Thank you, Dr. Ashish and Dr. Jarna for moderating this session, and thank you, Dr. Ashwini, for presenting, and thank you everyone for attending this session. We will conclude. Thank you, everyone.
Thank you.
Thank you. Yes, yes.
Yeah.
Thank you so much, ma'am and sir. Thank you. Thank you for this.
Thank you, Dr. Ashwini, Dr. Jarna, and everyone. Shailesh, thank you. Bye. Bye.
Yeah, thank you.